Hi, this is part 2 of blood administration, and I just got back from the blood bank with my unit of packed RBCs. I just want to remind you also, don't forget that you must do patient teaching regarding a unit of blood. Explain to the patient signs and symptoms that they need to be aware of in case they experience them, and then they need to call their nurse ASAP. Some hospitals do have policies, little booklets, like teaching booklets that you hand to patients that tell them about the transfusion that they're receiving, about any symptoms that they need to be aware of and whatnot. So that's also very good if you can get a hold of one of those. I am back, and I have just gotten back to the unit with my unit of packed RBCs, and I am going to ask another licensed professional to come in and double check this information with me because it's important. And it's important that we do this at the patient's bedside. So I have a unit of packed RBCs. For RU my type. ID number 52256. And the blood type is AB, RH positive. And the donor unit number is 0016157. And the blood band number is ABC987. Okay, and it expires 10/15/10.
Expiration date.
Okay, and then Ms. Mack, she's going to go ahead and verify that she's checked that information with me. She's checked everything. Thank you very much. And we do indeed have the right unit of blood for the right patient. And in real life, guys, you're going to have actually a little requisition form coming off the blood bag itself that has all the same information. So as you noticed, when Ms. Mack and I were checking this and verifying this unit of blood and the information that we needed to check, that we were looking at the requisition that's coming off the blood bag, we're looking at the patient's arm band, plus the blood band, should they have one. Not every patient's going to have a blood band or a blood ID number. And we were looking at the requisition form. Okay, so we're matching all that information. Now I'm going to go ahead and just gently rotate the blood bag, mix up the preservative, mix up the cells a little bit. I don't want to shake it, just gently rotate it. But it's also at this time that I can actually assess the blood, make sure it's not brown, bubbly, leaking, anything that might indicate that there's bacteria in there. Okay, and at this point also, I'm going to take the patient's vital signs just before I start this transfusion, just to make sure. Now the vital signs were fine before I went to get the blood, but it's essential that you put the pre-transfusion vital signs on this requisition form. So I've taken vital signs are fine, temperature's fine. I'm going to go ahead and before I actually spike the blood bag on this Y port, I'm going to actually prime this Y port. And I'm just going to prime it by loosening the cap and opening the clamp on this Y arm. And just by gravity, the normal saline should prime that little tube in, which it did, and it is, okay? And there, that's all primed. Now I'm going to go ahead, take my spike out of my blood bag. I'm going to go ahead and spike it with the other Y arm. I'm going to close the normal saline on the clamp on the normal saline. Go ahead and hang my unit of blood. Okay. And I'm going to open up the clamp on the unit of blood. At this point, and because blood is so cold, if we put the blood at the rate we want it to run it for the first 15 minutes, which is about 75 milliliters an hour, it's going to run so slow that it's going to take it lots of, like half an hour at least, to get down to the IV port. So what I'm going to do is I'm going to run it really fast. If you were using a pump, you could run it at 999. just to push that 15 cc's of normal saline in. And the minute the blood gets down to the saline lock on the patient is when I want to start my time in my first 15 minutes. Because as we said in lecture, the first 15 minutes is the time when someone, if they're going to have a reaction, most likely has that reaction. So because of that reason also, I'm going to also run this blood at a slower rate for the first 15 minutes. So it's down to the saline lock, and I'm going to run this blood at 75 milliliters an hour. So again, if I figure out my drops per minute, 75, my tubing is 10 drops per ml, and if I take my magic number and take 75 and put 6 into 75, I think it's about 13 drops a minute. So I'm going to go ahead, take that 13 and divide it by 4, and should come up between 3 and 4 drops every 15 seconds. So I'm going to go ahead and regulate that. Alrighty, so I got that, and it's running at 75 milliliters an hour for the first 15 minutes. I've documented my vital signs. I'm going to stay in the room with the patient. I'm going to observe them for any adverse reactions. This is where I can grab the patient's chart. I can start documenting on the bedside chart. I hung a unit of packed RBCs. I could document that the vital signs and what they were pre-transfusion. That they had a number 20 angiocath in their left antipube area, patent without complications, and that their lung sounds are clear, so I can kind of document donor unit number was, and patient tolerated procedure well currently. We'll continue to monitor and follow as per hospital policy. So for time's sake here, we're going to say that 15 minutes is up, and I'm going to go ahead, I'm going to retake vital signs on the patient. And vital signs are fine. I'm going to document them on the requisition form. And I'm going to proceed to follow the hospital policy, because each policy is different at each hospital. At this point, because it's best if we can get the blood in at a rate that's as fast as the patient can tolerate, I'm going to try to get this unit of blood infused, over a couple of hours. So now that I see that there was no reaction and that vital signs are fine and lung sounds are fine, I'm going to go ahead and I'm going to bump the rate up to 125 milliliters an hour. Okay, so I'm going to go ahead and do that. And it should go in, so that's going to get that in well within our time frame of our whole 4 hours time limit. And I'm just going to monitor the patient as per hospital policy. And when the blood is done, I'm going to then close the clamp, the Y side of my blood unit. I'm going to open the clamp of the saline, the Y side of this will run into my saline, and I want to infuse it. And you can infuse it at a rate that perhaps the blood was running at, 100 cc's an hour, and infuse about 50 cc's, which would put about 50 cc's of normal saline in over a half an hour, just enough to clear that line, because there's a lot of residual blood cells in that line even after the transfusion bag is empty. So we're going to go ahead and flush the line, and we're going to make sure that you take vital signs post-transfusion and document them on the flow sheet. And we need to do that before we actually start flushing the line. When it's all done and it's all flushed, what we can do is close our clamps, unhook it from the patient, put all of these, the blood tubing, the blood bag, the normal saline bag, all in a red biohazard bag, take it to the dirty utility room and discard it. Go ahead and flush the saline lock again, make that so it's patent, there's no blood residue in that, and lock it off, and continue to monitor the patient and continue to monitor lab